Hello, everyone. Thank you for joining us for this webinar series, the Med Safety Exchange, a joint venture by the Institute for Safe Medication Practices Canada, ISMP Canada, and the Canadian Patient Safety Institute, CPSI. Just a reminder that this webinar will be recorded so that it's available to those who couldn't make it at this time. We have all the lines muted, and we encourage any questions or comments to be typed to us in the chat box, and then we'll read them out loud at the end of the webinar during the discussion. I'm sure most of you are aware, but for those who may be joining us for the first time, the purpose of this webinar series is to provide another modality and platform whereby healthcare providers can share local analyses and the follow-up safety improvements and quality improvements for us all to learn from. Every webinar will have roughly the same structure but with different content. This webinar will have one med incident analysis regarding low-dose methotrexate and considerations to prevent toxicity, and a description of a med safety initiative around preventing adverse drug events. This will be followed by the observatory for a med safety update, and then finish up with a discussion period where we read out your comments and allow the speakers to elaborate. Anonymity is a choice for all those involved in the webinar, so I'll only introduce speakers briefly, and they can then share as much or as little as they like about themselves and their practice site. I'd like to invite the first speaker to discuss an incident analysis involving low-dose methotrexate and its safety considerations to prevent toxicity.
Thank you very much, Ambika, and thank you very much to ISMP Canada as a whole for allowing me to spend a little bit of time discussing this case today. My name is Andy Zabricki, and I work as a staff hospital pharmacist. I've been working on a medicine ward for a number of years. And as Ambika mentioned, today I'm going to be reviewing some safety considerations for low-dose methotrexate using a case example which I came across in my practice. So what I'm going to do is I'm going to briefly review the case that I was involved with at the beginning. And then I'm going to do a quick review of the medication methotrexate itself. I'm going to spend some time reviewing the literature that exists on low-dose methotrexate toxicity. And then I'm going to come back to the case in more detail and conclude with some points on how to try and prevent similar cases from occurring in the future. So here's the case overview. RL is an elderly patient admitted for pain control to the hospital after suffering a fall. The patient takes low-dose methotrexate once weekly for rheumatoid arthritis. Over 2 weeks into the hospital admission, the patient becomes profoundly pancytopenic with mouth sores. And upon noticing this, the physician suspects methotrexate toxicity, and it is immediately stopped. Unfortunately, despite aggressive measures, the patient fails to improve and passes away 2 weeks later, so about 4 weeks into the hospital admission. So we have a fatality with low-dose methotrexate, attributed to low-dose methotrexate. So just to review methotrexate a little bit, it's an antimetabolite medication that inhibits dihydrofolate reductase. And it's a mainstay of treating some autoimmune conditions such as rheumatoid arthritis and also psoriasis. It's given in low doses for these indications, usually dosed 7.5 to 25 milligrams once weekly. It's primarily renally eliminated and has a pretty quick half-life. In healthy individuals, the half-life ranges from about 3 to 10 hours. Some of the adverse effects of taking methotrexate in low doses, the more common and mild ones would be GI effects, such as nausea, diarrhea, and some mild mouth sores, and also some central nervous effects, such as fatigue. And these effects, especially the GI ones, tend to show up 24 to 48 hours after taking a dose. More rarely, but also more severely, patients can have much more severe mucositis and GI toxicity, pulmonary toxicity, hepatotoxicity, and myelosuppression. And actually, over the course of a patient's methotrexate therapy over the course of years, 1 to 3% of patients may actually develop some degree of pancytopenia. And that's what I'd like to focus on in this talk, the pancytopenia, and also the severe mucositis, because these are the adverse effects that are most commonly seen from the literature in patients who actually do present with toxicity. So speaking about the literature a bit, is severe low-dose toxicity well reported? And the answer, if after doing a PubMed search, I can say that yes, it definitely is. There are numerous case reports in the literature of one case here or two cases there. And a little bit more comprehensively, there are 2 retrospective reviews noted in the literature since 2000, one done 12 years ago and one done 3 years ago. And so just to summarize them briefly, these 2 reviews were both done at large medical centers consisting of about 1,000 or more beds each. And what they did is they looked at several years of retrospective data at their sites, and each found that each year about 5 to 7 patients at each site were presenting to the hospital with low-dose methotrexate toxicity. And the mortality rates were significant. About 1 in 4 patients, 25 to 28%, were dying. And all the patients who were dying were noted to be pancytopenic. So I just want to talk a little bit about what are the known or potential risk factors associated with methotrexate toxicity. One of the first ones is changes in methotrexate doses. So if a patient newly starts methotrexate or increases their dose or restarts it after a hiatus from therapy, this can be associated with an increased risk. So important to monitor during these phases. Also in terms of dosing, medication errors, occasionally there's a mix-up where methotrexate is given once daily instead of once weekly, and this can greatly increase the risk of toxicity in a short period of time. Renal impairment is another risk factor. Of course, since it's renally eliminated, renal impairment will cause the level of methotrexate to go up, increase the exposure. Low albumin might be a risk factor. Methotrexate is only 50% or so protein bound, but decreasing the albumin will nonetheless have the effect of increasing the level of free drug. Older patients tend to suffer from toxicity more. Folate deficiency is a risk factor because methotrexate interferes with folic acid reduction, so we often give folic acid concurrently to minimize the risk. And pharmacogenetics might play a role as well, although this area needs more research to see if particular individuals might be more susceptible. And finally, and important to this case as well potentially, I'm a pharmacist, so I like to look at drug interactions. Sulfonamides or sulfa antibiotics would be a very good example of a combination we want to avoid with methotrexate. It also interferes with folic acid and can have synergistic toxic effects. And also, I'd like to highlight 3 broad classes of medications, NSAIDs, penicillins, and proton pump inhibitors. They are also believed to increase the risk of toxicity, potentially. However, I want to mention that much of the drug interaction data for these 3 classes is taken from studies looking at high-dose methotrexate for oncologic indications in much higher doses than we see for treatment for rheumatoid arthritis. So some caution in applying the same risk for low doses and drug interactions. Just briefly, I want to mention one risk factor that's not on the list here is the methotrexate levels for low doses. It's been found that it's more a function of the duration of exposure than the peak levels for determining which patients develop toxicity and what their outcomes are. So with that, I'm going to go back to the case now. And so again, we have our elderly patient admitted to the hospital after a fall. And this patient was on a lot of medications, 17 home medications, and I'm just highlighting the pertinent ones here. Methotrexate, 20 milligrams once weekly, so a good dose of methotrexate for the low dosing range. And an NSAID, a non-salicylate NSAID, a COX-2 inhibitor, celecoxib, 200 milligrams, taken twice daily. So in hospital, the home medications were all continued, and ramipril and hydrochlorothiazide were also added during the first week in hospital. Also, 15 days into admission, the proton pump inhibitor esomeprazole was added for nausea and upset stomach. A day after that, the patient's weekly methotrexate dose was given. About 48 hours after that, the progress note in the chart indicated that herpes simplex virus of the mouth was suspected. 2 days after that, the patient was complaining of severe mouth pain, mouth bleeding, and was also noted to be neutropenic. One day after that, the physician suspected methotrexate toxicity. Hematology was consulted and saw the patient, and the methotrexate was stopped. And at this point, the patient had become pancytopenic. A day after that, they started leucovorin rescue therapy, so intravenous folinic acid, and broad-spectrum piperacillin tazobactam as well as filgrastim was suggested if the patient became febrile. Later that day, they did actually start the pip/tazo and the filgrastim, and over the course of the next few days, the patient required packed red blood cells as well as platelet transfusions. Unfortunately, the patient didn't recover and passed away 27 days into the admission. So here is a chart that looks at the pertinent lab values from this case. So just looking at the admission column, you can see initially the patient came in with relatively normal labs. The hemoglobin was maybe a little bit low. Serum creatinine was high normal, that's in micromoles per liter. And the albumin was normal in this case as well, so that wasn't a factor. It was low normal at 36 grams per liter. But then you can see that esomeprazole was given on day number 15 and methotrexate given on day number 16. And by a week after this time, you can see that everything had really gone south. White count was low, neutrophils were actually unmeasurable, the hemoglobin dropped as low as 59 and the patient required those transfusions. The platelets went all the way down to 13. And again, the patient passed away on day number 27. You can see that things did start to bounce up right on the day that the patient actually passed away. The hematologist was kind of interested in seeing those lab results and saw that, yeah, looks like the patient was on the way to recovery, but just didn't quite make it out of the woods. So, just advancing the slide here. Some potential contributing factors in this case that I alluded to before. So we have an elderly patient who, they tend to be the group who are more sensitive to the effects of toxicity. There was some degree of acute renal impairment. I didn't mention it there on the last slide, but you would have seen it, that the creatinine did bump up somewhat during the course of admission and eventually did actually double. I am not uncertain exactly why this happened. Perhaps the patient was a bit dehydrated, or perhaps the effect of adding the hydrochlorothiazide and ramipril early in the course of admission may have played a role as well. And then speaking of other drug interactions, of course the patient was on methotrexate, celecoxib, the NSAID, and started esomeprazole, the proton pump inhibitor. But I do want to mention that the literature is equivocal on what the effect is here between low-dose methotrexate and these drug interactions. Because again, much of the data is taken with high doses, and the risk of an interaction is not necessarily the same between high-dose and low-dose methotrexate. There's one recent review in the literature that doesn't support a substantial risk with low-dose methotrexate, NSAIDs, and PPIs, but at the same time, they don't entirely rule it out altogether either, and say that they can't completely rule it out in a small number of cases. That said, some of the other literature, including one of the retrospective studies that I looked at, suggested that there is a potential association of toxicity between low-dose methotrexate, PPIs, and NSAIDs. And then on the other hand, going back the other way again, there are many, many patients who tolerate and benefit from NSAIDs and PPIs with low-dose methotrexate and are walking out there in the community and are having no problems. And this is a real dilemma. So we have to balance the benefit of treatment versus the small risk of toxicity. So in terms of this case, I think it's wise to entertain the possibility that esomeprazole may have contributed toxicity, given the very suspicious timeline of events. though there was the confounding factor of the acute renal impairment as well. So the main problem in cases like this is that there is no good way to predict who will develop toxicity and who won't. And this is what I struggled with a little bit when I was trying to come up with some absolute recommendations for this talk. But I'll give it a try anyhow. So a couple of years ago, ISMB Canada actually came out with a safety bulletin mentioning some of the risk factors and some of the harm that occurs with low-dose methotrexate. And they came up with a number of suggestions, which are summarized on this slide here that I'm just going to review briefly. There were suggestions given for computer system administrators, prescribers, and pharmacists. So, for example, computer system administrators were encouraged to ensure that for order entry, dosing frequency would automatically come at this once weekly to avoid the possibility of once daily dosing, and again, prolonging that exposure to methotrexate. Prescribers are, of course, supposed to consider patients' baseline risk factors, such as kidney impairment, and identify if there are any changes in risk factors as well. And pharmacists also play a really important role, of course, too. In the community, they play a very important role in that any patient who comes in with a methotrexate prescription should be clearly notified of the risks and how to take it properly as well. I'm just going to touch on a couple of things that I do at my site, or a couple of risk minimization factors that are in place. So my computer system, if I'm screening or entering an order for methotrexate, I do have a warning that pops up on my computer saying that orders for daily dosing would be unusual and require thorough investigation. When I enter medications, I also have drug interactions popping up, of course, and methotrexate and a PPI, for example, would show up as a major interaction. Now, the problem is, again, I have to interpret what exactly to do with this, because it's not cut and dried. And of course, working in a hospital setting, I'm easily able to review labs at the time of order entry, such as serum creatinine and albumin. So just a bit more about minimizing the risk as much as possible. And again, I'm going to use the word minimize and not eliminate, because one of the things that was really discomforting to me in this case is that the patient developed toxicity while in a hospital setting and passed away in a hospital setting despite being in a prime setting for really close monitoring. So that's kind of troubling. Despite that, here are the monitoring guidelines for blood work. If you look at a product monograph, the CBC should be done at baseline and be checked at least monthly for patients on low-dose methotrexate, and more frequently with dosing changes. Renal function should also be checked at baseline and at least every 1 to 2 months, and periodic serum albumin should also be done. Screening for drug interactions that may increase risk is also important, but again, it's difficult to absolutely recommend how to deal with these interactions. One suggestion that I have is that if a medication is being used, but not absolutely indicated, for example, using a proton pump inhibitor without a really good indication, consider stopping it, especially if the patient has other risk factors such as renal impairment. So we can perhaps take away a small risk and at least make that a zero risk in terms of there's no chance that a PPI would be contributing to toxicity. And again, patient awareness is very important. They should be aware of the signs of toxicity. For example, if they have severe mouth sores, rather than the more common mild ones, or say a lot of difficulty swallowing a couple of days after a methotrexate dose, I would suggest that they should probably have that urgently looked at. Understanding their dosing clearly, making sure that they take it weekly, not daily, and not to titrate their dose on their own without close supervision of a medical professional. And to make sure that they understand the risks as well, such as that if a patient becomes dehydrated, this can cause renal failure and increase the risk of toxicity. So stay well hydrated And again, be aware that there are potential medications that interact that are over the counter, such as NSAIDs, or even taking some medications, some proton pump inhibitors are available without a prescription in small quantities. And finally, healthcare provider education is important as well. So reading ISMP safety bulletins, for example, or listening to a talk like this one today. So just to summarize, I'd like to say that methotrexate remains a key agent for diseases such as rheumatoid arthritis. It's important not to be hypervigilant and be worried about every single patient out there, but there is a rare but life-threatening risk of severe toxicity. It most commonly presents as pancytopenia, and the mortality is about 25%. Unfortunately, predicting which patients will develop toxicity and why is still not completely understood, and the treatment is largely supportive. So it's really important to minimize risk factors as much as possible and educate patients where we can. Thank you very much.
Thank you, Andy. We have long known that methotrexate is a high-alert drug, and over the years we have collected related to methotrexate. Your case highlights that it's not only high-dose methotrexate or mistakes with regimens that impact safety, but also that low dose taken weekly in the presence of certain risk factors can lead to harm. So it's a reminder to all of us that we need to remain vigilant at all doses of this high-alert medication. I'd like to now introduce the second speaker to describe her team's work to identify a specific source of adverse drug events and strategies to prevent harm.
So my name is Corinne Hull. I do research on adverse drug events, and as an epidemiologist, I'm really interested in systems issues that can help us reduce harm from medications. So that's the lens from which I'm going to present a couple of cases from. So what I'm going to do is, based on epidemiologic data and cases that we found in a quality improvement, a large quality improvement project where we did medication review in incoming patients looking for adverse drug events to outpatient medications, I'm going to present a couple of very common cases of preventable adverse drug events. And I'd like to, in presenting that, highlight the importance of getting robust epidemiological data to understand the importance of the frequency of preventable adverse drug events. And we really use that epidemiological data to help us prevent, or to help us to understand how we can have the biggest impact when we subsequently try to understand what a good target for intervention might be, and hopefully we can discuss some lessons that we have learned so far. So the first case is a 57-year-old diabetic who presented to the ED that I work at with angioedema, and he had been taking captopril. He was placed in the trauma bay for monitoring. I was called to his bedside. His vital signs were all within normal limits, but his airway was very, very swollen, and he was having difficulties breathing. We did what we normally do in these cases, even though it's very, very rarely effective. We started treating him for an allergy. His airway didn't really change. He didn't require FFP or anything else, but we did have to observe him for about 8 hours in the trauma bay. And it was pretty obvious once we looked at his medications that this was likely angioedema due to captopril. This is something that we see very commonly in the emergency department. And we didn't really think much of it. And when we went back and we looked at this patient's medication profile and his PharmaNet profile, interestingly enough, he had been exposed to a different ACE inhibitor only 3 months ago. And 3 months ago, he had presented to a hospital that's about 3 kilometers away from our site. And unfortunately, this gentleman, between the first hospital visit and the second hospital visit, he knew he had had an adverse event to a medication, but patients generally don't remember medication class. And for patients, it's very difficult to determine whether a medication that they're being given that has a different name is the same class of a medication to one that they previously have experienced an adverse drug event. So the patient didn't realize that both drugs were in actual fact a drug of the same class, and as is very common within our fragmented healthcare system, the adverse event that was diagnosed in the first hospital did not, that record that remained within the first hospital's medical record, and it never got transmitted across hospital sectors. So this is a gentleman who has multiple care providers, a family physician, and multiple specialists prescribing for him. So one of those care providers who did not realize that he had had an adverse event to an ACE inhibitor 3 months ago re-prescribed another one, and we believe that's the case quite simply because obviously the patient is still diabetic. So the guidelines push chronic disease management for these patients. So I'll move on to the second case. Thanks. The second case is a gentleman that I saw more recently, 75-year-old gentleman with atrial fibrillation and renal failure. And this was a gentleman who was relatively recently on, so within the past year, he had been placed on dialysis. And he presented to the emergency department feeling weak and dizzy, and he was no longer able to stand. So he had been feeling weak and dizzy for a few days, and then that morning he actually wasn't able to get out of bed. So the nursing home where he stayed at called the ambulance. I'd like to emphasize that this was a patient who was, still relatively active, still able to mentate. This was not your palliative nursing home patient. So this gentleman was found to be very, very bradycardic with a low blood pressure. And his ECG didn't really show a particular block of any kind. It just showed profound sinus bradycardia. And his kidney function was consistent with him being on dialysis. So he was on bisoprolol, which is a relatively long-acting beta blocker that's renally excreted, and he was on that to rate control his atrial fibrillation. So we, kept him, called the CCU. He didn't really require any other management aside from a little bit of fluids. But because it's a long-acting medication and this is a dialysis patient, he required an admission to hospital. And as we went over his medications and reviewed them, the pharmacist came up to me and said, "Did you realize that he was actually already diagnosed with bisoprolol-induced bradycardia this summer?" And sure enough, when we went through everything, it turned out that one of the cardiologists had dictated a nice discharge summary from our hospital, and he had previously had an episode of very significant bisoprolol-induced bradycardia. And the cardiologist then had recommended stopping the drug. So that was buried within a discharge summary, and this gentleman is a gentleman who gets admitted relatively frequently. So it was actually difficult to find the record of that, but it was included in the discharge summary, and nonetheless, this patient's medication was restarted within, I don't actually know the exact time frame, but we saw him approximately 3 months after that. So this, again, was another repeat adverse drug event to the exact same medication, not even the same medication class, but to the exact same drug as he had previously suffered an adverse drug event. So we got really interested in this phenomenon of repeat adverse drug events. And so because I'm an epidemiologist, I get very interested in the relative frequency of different types of harm, because from a systems perspective, it's good to target individual cases that are particularly noteworthy, like the one that we just heard about. But when we try to design interventions to minimize harm, we have a better chance of having a bigger impact if we target events that are very frequent. And so one of the things we have very good data on, we have a case series that captures adverse drug events to outpatient medications that collects data on about 14,000 patients who have entered the acute care sector. And about 1,400 of those have suffered or have entered into the acute care system with adverse events to outpatient medications. So it's about 1 in 9 visits. So once we started noticing this, just as we were going through these cases, this pattern of repeat adverse drug events, we actually were interested in looking at high priority targets for intervention. And Health Canada gave us some money to actually look specifically at this concept of repeat adverse drug events. So when we look at adverse drug events, this is what the epidemiological data tells us, and these are all prospectively identified events that have been identified by clinical pharmacists and that have also been seen by physicians. Whenever there's a discrepancy between whether or not this is an adverse drug event or something that could possibly be explained by an alternative diagnosis, there's a formal adjudication that happens between a physician and pharmacist. These are systematically selected patients, so we don't have any selection bias in these. These truly represent patients coming into the acute care system. So when we look at the types of adverse drug events that we see, and these numbers remain very constant actually over time, adverse drug reactions make up the largest component of these. We see many dosing problems with patients. We see many adherence problems. Then you can actually see that traditionally, drug interactions and errors have actually featured very low in terms of incidence of adverse drug events causing patients to come into the acute care sector. Now, from a systems perspective and from certainly in the lower mainland of BC, we've focused quite heavily on medication reconciliation, the implementation thereof, and we're now implementing a computerized provider order entry system, which is very costly. Those types of health systems interventions are probably best suited to address events that occur due to drug interactions and those that occur from errors. Now, up until very recently, we haven't really conceived repeat exposure to a contraindicated drug as an error that is highly preventable through CPOE. I hope it will become one of those ones. But as you can see, the adverse drug events that we found that were repeat events due to re-exposure to the same or a same class drug were much more common than the events that we see that are due to drug interaction or errors. And the repeat adverse drug events, they're actually distributed across all of our really common categories of adverse drug events. So the most common category of repeat adverse drug events are actually repeat ADRs that basically bounce around our system. And of those, about 80% are preventable. So when we thought about this, when we took a step back and we thought about this, what really appears initially as a patient-level problem, so the patient comes in because, I'm just going to use other examples that we commonly saw. I'll use deliberately a non-adherence example because they were not adherent to their seizure medications because they ran out and they went on vacation without filling their prescription first. What appears initially to be a patient-level problem, so they stopped their whatever your favorite seizure medication is and they presented with a rebound seizure into the emergency department off of their seizure medication, or they were re-exposed to an anti-inflammatory and they presented to hospital with a GI bleed because a walk-in clinic physician thought that they might have had new manifestation of gout and chose to treat with an anti-inflammatory. What appears to be a patient-level problem, really when we thought about it, appeared to be a problem of fragmentation of care. So when an adverse drug event is serious, even if the patient goes to see their family doctor, they actually often get referred into the emergency department because family physicians rarely can access all the diagnostic modalities they need to work up these events properly. And most of the patients actually present directly themselves because it's usually an acute and unexpected problem. And we generally diagnose the adverse drug event in a health record that is specific to that hospital or that hospital system. But if you think about it from a patient perspective, the vast majority of patients, they all want to go home. So the patient is really working on transitioning out of that hospital system back into the community. But we have very poor ways of actually flagging that an adverse drug event happened to all of that patient's care providers, particularly when they're a patient who has complex disease. It's just enough for them to have 2 or 3 providers who may be prescribing to that patient. Sometimes I'm told, well, that's because it's up to the family physician to actually, wait for the consultation results and to prescribe to that patient. And unfortunately, that's simply not realistic in our system where many patients actually don't have family physicians and they have to rely on a walk-in clinic to get their prescriptions refilled, and they probably can't access that physician in time. And so oftentimes they are relying on their specialists or the walk-in clinic doctors to manage their chronic diseases. And then the individuals who are completely out of the loop are our community pharmacists, who could play a really important role here in ensuring that if a re-exposure happens, it's really carefully explained and the pros and cons of a re-exposure are carefully weighted. So even though in British Columbia we have a central database that captures all of the dispensed medications, currently where we diagnose an adverse drug event, which is in hospital, we actually have no ability to enter that information in a standardized way that could subsequently be accessed by the other areas in which care is provided, and particularly by community pharmacists. We don't have a way of getting that information into that central database. So in thinking about this, and we've now done probably focus groups with probably over 130 care providers, including outpatient pharmacists, inpatient pharmacists from different hospital settings, physicians, both hospitalist physicians, emergency physicians, and GPs. What we think a solution may be, or what we think would be promising, is if we could generate the software that allows hospital-based care providers, where those serious adverse drug events to outpatient medications commonly present to enter that information in a standardized way. And in a really abbreviated, standardized way. So we've done a lot of work on identifying how much information needs to be documented and how can we do that in a really efficient, user-friendly way without documenting too much information, because the minute you make the documentation lengthy, care providers who see multiple patients a day, it's too burdensome for them. It takes away too much time. But if we could have that software in the hospital setting where these events are commonly diagnosed, and that information could be integrated with a central medication dispensing hub or a system like PharmaNet, which is where institutes like Canada Health InfoWay would like every province to go towards, then that could be a very effective way to get brief, standardized information back out to the community pharmacies. In British Columbia, community pharmacists, they have to enter every medication that they dispense into that same PharmaNet database, which in some ways provides a hard stop. And so the information that is used by primary care providers to record the adverse drug event could then be used as a hard stop. And because care providers across the spectrum, in community, in long-term care facilities, in rehab facilities, in different hospitals, access that same central PharmaNet data to start doing medication reconciliation on, that would probably be a very promising way to reduce these unintentional repeat exposures to culprit medications. So what our group has focused on, so maybe what I should just digress and say real quickly, 2 years ago I had the opportunity to meet with the CEO of Canada Health InfoWay, along with Dr. Yu, who was there as well from ISMP Canada. And we were asked to ask a research question to try and understand whether this is not just an observation in BC, but a problem in other jurisdictions in Canada. And if you look up Imagine Challenge and adverse drug reactions, you'll see that one group from Ontario was able to use the administrative data in Ontario, and they found that 54% of their elderly patients across the province who were admitted for hypoglycemia while they were on glyburide, so a contraindicated medications in seniors with hypoglycemia, and patients who were admitted with falls who were also elderly but on benzodiazepines and neuroleptics, 54% of those individuals were re-exposed to that high-risk medication within only 180 days. Most of these patients were re-exposed within 90 days of their hospital admission for the adverse drug event. So I just want to highlight that to let you know that we have looked at other jurisdictions, and this is truly a system-level problem in Canada. So what we have done in the last couple of years is we've actually, through research grants, we've been able to design the software conceptually that we think can help us all close this information gap and provide safer care. And what we did is we first did a systematic review of adverse drug event reporting systems, and then we used that information to develop what we call a minimum required ADE data set. And then, as I alluded to, we did a lot of participatory workshops with different frontline care providers and focus groups to understand what information we truly need, what information is important, and what barriers and facilitators exist on a system levels within different aspects of the system to actually implement this kind of tool. And then what we did is we tried to understand what our workflow is, because if we integrate the software into the workflow logically in terms of reflecting how we think and how we provide care, it's much easier for people like me and those of you who are primary care providers to actually use the software. So we've piloted and refined a paper-based design, and we're actually in the process of working with a developer to actually program the software, and we actually hope to be piloting it this winter. So this will just give you a snapshot of the type of concepts that we're looking at. So this is not the finalized design. This is really the screenshots that have allowed us to think about it. So imagine a software that as you document the medication history, or you can ingest that from a system like PharmaNet. Anyways, so on the left-hand side of your screen, you'll see under Select Suspect Drugs, you'll see a medication history. It's a very brief, very cursory medication history that is incomplete. That is a medication history that can be pre-populated from any electronic best possible medication history system, or it's something that can be pre-populated from a PharmaNet or whatever your electronic information system may be. It can be pre-populated from that. And in the software that we're envisioning, you could tick on the suspect drug, and by ticking on that suspect drug, as you can see, a tick appears, and that tick pre-populates dosing information. That dosing information can be changed in case the best possible medication has not yet been done. So you can change that, but by pre-populating it, it makes the data entry much, much quicker for primary care providers. And subsequently, what clicking suspect drug allows you to do is it allows you to enter the details about the adverse drug events that primary care providers tell us they need in order to make a subsequent re-exposure decision. So we need to know what the type of adverse drug event is, because obviously the action taken if a patient is non-compliant and having rebound seizures is going to be very different than the action taken if the patient has an adverse reaction where they should not be re-exposed to the drug. So we document the adverse drug event type from a drop-down menu, and then we use some of you may be aware with MEDRA terminology, which is a really unambiguous terminology that is updated routinely and that is provided free of charge to nonprofit organizations. And that terminology maps symptoms to ICD-10 codes and make sure that we don't make errors in documentation, and make sure that the terminology we're using is unambiguous and not replete with abbreviations that could be confused. So it allows us, using predictive entry, to enter symptom, and it maps it to a diagnosis. We can enter relevant laboratory data if we would like. And then what it allows us to do is it allows us to provide a recommendation, such as discontinue the hydrochlorothiazide. We don't need to have it linked up with prescribing functionality, but if we could, that would probably be the ideal world, where a pharmacist could recommend how that medication would be replaced, because it's the unmanaged chronic disease when you remove a drug that subsequently pushes other care provider to restart the culprit drug. So it's not a bad idea to recommend an alternative or order an alternative if you're a physician using this. And subsequently, data on causality and outcome is something that we always like to know about when we're making decisions about re-exposure. That information is not mandatory information, but most pharmacists, when we did our focus groups, would like to have access to that information. And so what happens with this report lives ideally within an EMR or within a server. It can also be cloud-based technology. And what we're working on with the Ministry of Health very closely is we're hoping to actually integrate these now standardized information, the standardized information into the PharmaNet database. When a community-based care provider, or when I, try to re-expose a patient to this medication because I'm unaware that this patient previously had an ACE inhibitor-induced angioedema reaction that was documented in a different hospital, it would allow me, when I try to, re-expose the patient to an ACE inhibitor, it would provide me with this type of an alert. So this is an alert to hydrochlorothiazide-induced hyponatremia. So provide this type of really succinct, unambiguous event summary that would appear and would allow me, together with the patient, to make a rational represcribing or re-exposure decision. And if you click on the details, you have access to all of the details that were entered. So we're hoping to pilot test and refine the data entry interface of the electronic prototype this winter. We have business cases that are at the ministry that are being developed to actually integrate the pilot interface with the PharmaNet database. What we want to do before we do the final hookup is validate the data for accuracy and completeness. And the other thing that we're working on is on hyperlinking the software with the EMR that's being developed. And we think that's really important because the research result that I showed you, that 28% of all adverse drug events are due to re-exposures, 80% of which are inappropriate, that data actually comes from within one hospital system. So even if we can hyperlink this software within one hospital system's EMR, including the other hospitals that are attached to that single hospital and the clinics attached to that hospital, we can probably significantly reduce repeat ADRs. We have been asked to think about things like, well, how likely is this going to benefit people? And we think that the business case is incredibly robust. Because adverse drug events to outpatient medications are so common and so commonly make patients come into our hospital system, and repeat adverse drug events are such a large chunk of those outpatient adverse drug events, it has a very, very significant can have a very significant impact on reducing emergency department visits and inpatient admissions. So in British Columbia, the base case calculations are incredibly robust, and they're probably actually more robust than other systems that we're currently pushing for implementation. So I think this is really something that from a systems level we should hopefully all be considering for our institutions. And I think this is just a visual demonstration of the benefits realization in BC. And just for those of you who are sort of surprised by how compelling these numbers are, we have based these numbers on prospective data on over 14,000 patients in Ontario and in BC that originate from 5 acute care hospitals. These include both urban community hospitals and urban tertiary care hospitals. And even if you're sort of a skeptic and you want to minimize all of our estimates, the bottom line is where we have minimized the efficacy. We've actually gone down and assumed that this type of interface would only prevent 20% of all redispensing and represcribing episodes. And we've minimized all of our estimates. And even when we minimize all of our numbers, you can see that there's a very likely substantial benefits realization for our province here.
Thank you, Corinne. Very interesting system to prevent unintentional represcribing of a drug that they've already had a reaction to. So we're running a little tight on time, but we'll get into the observatory for some quick med safety updates, and I think we'll probably tighten those up a little bit so that we have some time for discussion.
Hi, everyone. I'm Sylvia Hyland with ISNP Canada, and the Health Canada representative is unavailable to present today, but I'm going to do my best to share a few of their messages for today. So the Health Canada team reviews adverse drug reaction reports and medical device incidents, and their slides in this presentation, such as this one, share the types of stakeholders that report to Health Canada, and also that Health Canada works with other regulators, including regulators in other countries, and also reviews the scientific literature. So In terms of triggers, for understanding the triggers for their risk communications, they do have standard procedures, and the triggers include a need for recall, a serious or emerging risk, a change in a safety profile, or concerns in packaging, naming, and drug shortages. They have various mechanisms for communicating risks to their various audiences. Just to highlight a few of the new safety issues that have come to Health Canada's attention and have been shared in safety reviews: Solumedrol and a risk for serious allergic reactions in patients who are allergic to cow's milk, and the monograph has since been updated. Protein pump inhibitors, there are many, and they reduce stomach acid. These drugs can interfere with laboratory tests, and warnings for these drugs have been updated through the work of Health Canada. In November, they also issued safety information about green tea extract that contains a natural health product and has serious risks of liver injury. Also in November, there was a safety review published on breast implants, and these are considered medical devices. And Health Canada found a low number of rare cancer cases that are linked to breast implants. And I think all of this work demonstrates the value of reporting concerns. The reports sometimes are low in number, however, can be very important for us to know about and increase our overall vigilance. There have been some recalls that Health Canada has issued. One of them includes a birth control product, it's a recent recall, and it's because there were reports of reduced size of tablets or smaller size tablets in the packages. And I think the last two slides in this presentation from Health Canada are a little bit about their methods of dissemination of information and also how we can all receive information that they are issuing. And I think one of the opportunities for all of us on the call is to help share information from Health Canada with our respective networks. And in that way, we are demonstrating our value for reporting and how that can help improve overall safety. And my last point would be to say that, as mentioned by Corinne, ultimately the opportunity for Canada will be to connect the various data sets at the system level for analysis, shared learning, and for closing the information gap. So I hope that covers the Health Canada topics for today. And if there are any questions, Health Canada is offered to connect directly with anyone who has questions. Thank you.
Okay. Thanks, Sylvia. So just to reiterate that, if you do have any questions, if you just submit them to the chat box or email them to me directly, I'll be able to connect with the Health Canada team. So we would usually have a CPSI update here, but in the interest of time, they've agreed to just have the slides available. If you have any questions about the documents presented here, again, please feel free to contact me directly, and I'll be able to connect with CPSI. Similarly, we'll also just kind of run through the bulletins. You can find them on our website, and the consumer-based one as well. So now we'd like to start the discussion period so we can continue the learning and have people ask some questions of the presenters. So the first question that we have is for our first presenter, Andy. So the question is, you've made the case that low-dose methotrexate toxicity is an important and often fatal event, but it also seems to be a somewhat random occurrence with only associations to guide us at this point. So do you think there is a role here at admission and discharge reconciliation to address labs, medication-related risk factors for toxicity, and maybe eliminating some drugs that are associated with that toxicity?
Yes. Hi. Yes, Ambika. I certainly agree that this is an important and often fatal event, although it is definitely rare as well relative to the large number of patients who do take low-dose methotrexate toxicity. And it is random, and it's not completely well understood which patients will develop and which patients won't. When I see patients on low-dose methotrexate at my site, I certainly do screen for lab values, and I screen for risk factors for toxicity, and I look for drug interactions. And as I mentioned in my talk, I'll consider stopping or perhaps changing a medication if it's feasible, such as considering ranitidine instead of a proton pump inhibitor, which wouldn't interact if there is a potential interaction with low-dose methotrexate. On the other hand, if I get a patient on low-dose methotrexate and an NSAID and the PPI who have normal labs and no other risk factors, and the meds seem to be beneficial, it's a tough call on what to do. You could argue that maybe just keep the medications as is and monitor very closely. We don't want to be hypervigilant, but we don't want to be negligent as well, and it's a tough balance. But I do agree it's important to screen at admission, screen at discharge, and for sure minimize risk factors such as interacting medications wherever possible.
Great, thanks. I do have a couple questions for Corinne. So one question, is the ADE report from PharmaNet connected to Health Canada ADR reporting system?
So that's actually an excellent question. I can't tell you whether or not it is connected, but I can tell you that we've evaluated the existing adverse reaction field in PharmaNet, and it's not being used. And the reason why the PharmaNet field is not being used is because you actually cannot populate it from the acute care sector. So even though, so this is another really big systems level problem, even though patients with serious adverse drug events, the ones we really want to prevent from happening again, they actually don't present in a first instance to community pharmacies. My understanding is that you can't actually enter the adverse drug event into the PharmaNet data fields in the hospital sector where the adverse drug event is diagnosed. And that's part of where we rely on patients or their families to transmit that information either to their family doctors and their community pharmacists, and a lot of patients can't simply remember. They're delirious, they don't speak English, they're very elderly, they have complex comorbidities, and I think this is where we're seeing the failure of the information transmission. So just to let you know, we evaluated the adverse reaction field in PharmaNet that's currently there in 10,000 patients, and we found exactly 0 adverse drug event reports in there, even though we diagnosed 2,000 patients with adverse drug events that required either emergency department visit or hospital admission. So I would say to you, whether or not that's linked with Health Canada data doesn't matter because it's empty for 99+% of patients, because the data capture system has not been developed to actually reflect where in the system that information becomes available for documentation. Does that make sense?
Definitely, and I think somewhat related, we have another comment. The person diagnosing the adverse effect has a duty to post this information. So what can hospitalists do right now to ensure this happens at discharge? Can the discharge
prescription... Well, they can do very little, actually. That's when we do our focus groups with, 130 care providers, they're utterly frustrated. They are utterly frustrated with the documentation systems that they have. These types of events, these are patient-level events. In other words, there's no point in reporting a repeat GI bleed on a PSLS system, and that's why care providers actually don't report these events in the PSLS systems or to Health Canada's MedEffect sites, because care providers, when I do these focus groups, they tell me, well, I report, but then nothing happens. And what I need is a patient-level report. In other words, Ambika, if you're the patient coming in with a repeat gastrointestinal bleed, they need to be able to report it so that any care provider can retrieve it on you. It has to be a patient-level report. And what care providers want is they want the system to remind themselves of the prior adverse drug events they have diagnosed and that other people around the system have diagnosed, because, a year or two might go by before the patient gets re-exposed, and a year or two later, for example, that adverse drug event might be in the last volume, like not the one that you currently have, but it might be in the prior volume of the patient's paper-based record. And the other thing that care providers tell us is it's not enough to just document it in the, within some consultation or even within a discharge summary, because discharge summaries, they're 2 pages long often. And for somebody like me as an emergency physician to go through every single discharge summary on a complex patient, that might take me 20 minutes. And those are 20 minutes that most care providers don't have because we're so pushed for time. So what would be much more effective would be to generate these patient-level, medication-specific or medication class-specific alerts where you only get reminded of the adverse event right about when you're to make that prescribing decision, And it's okay to have to enter it into a computer because that's when you get the alert. So then the care provider doesn't feel like they have to spend half an hour reviewing a patient's chart because they'll get that alert right before they make the mistake of represcribing. Does that make sense?
Thank you, Corinne. Very interesting discussion. Thank you to both of our speakers today and to all the participants sending interesting questions to us. I wish we could talk about this more. Unfortunately, we've run out of time for today. But again, if any of your questions were not addressed, I will be reaching out to the speakers individually and we'll get those responses to you. Again, I want to thank everyone for being part of the MedSafety Exchange, and I encourage you to reach out to us with any incident analyses that you have or any medication safety initiatives that you think would be valuable for others to learn from. The webinar for next month has already been posted, the registration, so please head over to the website and register now. I hope you all have a wonderful rest of the day. Bye for now.